Hello, my friends. Today we're going to talk about impotence, or to use the correct medical term, erectile dysfunction. We'll figure out whether this is really a sentence or if it's actually something that's easy and simple to fix. In which cases, what examination methods are needed, what each of these methods can tell you, and where should you start with diagnostics if you have this problem. You don't always need to see a doctor immediately. Sometimes filling out a questionnaire or just taking a test is enough. And you always need to see different doctors. Sometimes you need to see an endocrinologist, sometimes a psychotherapist, and sometimes an andrologist. And that's why, by watching this episode to the end today, we will learn how to figure out in which case you need to see which specialist, what kinds of examinations exist, which ones you need to do, and which ones you don't need to do. Because it's a waste of time and money, so watch until the end and you'll understand this topic. The first question is, what is erectile dysfunction? What is impotence? Because we always hear impotence, impotence, impotence. Is it a sentence or not? Actually, it's the same thing, but we've come to the conclusion that impotence is already a psychological trigger, and it's better to move away from this word to avoid using it. That's why we, as doctors and specialists, use the term erectile dysfunction. It doesn't sound as scary or intimidating and seems to have fewer psychological consequences. You're impotent isn't a nice thing to say. Is it even a proper sentence? What do you think? When answering this question, it's important to understand what erectile dysfunction is. It's not like a light, like the spotlight shining on me right now, that's either on or off. Because often you come to the appointment and say that your whole life you work just like a Kalashnikov rifle. The first thought, the first glance at a girl, and immediately I would get an erection, immediately I would have sex, and yesterday it didn't work out for me. He runs in wide-eyed, looks at me and says, "Save me, help me, something happened." Now let's look at the questionnaire. A simple questionnaire called the MIF5, the International Index of Erectile Function. Why 5? Because there are 5 questions, and it doesn't just say whether you have erectile dysfunction or not. There are point totals, and the degree of erectile dysfunction can vary. It can be mild, moderate, or severe. I'll tell you that when you don't have erectile dysfunction, you have the right to score 21 out of 25 points. So it turns out that for 4 out of 5 questions, you don't have to answer perfectly. Not that everything is always great for you. And that means there can be some slip-ups, sometimes there can be some mistakes, or for example, one of the parameters. You only scored 1 or 2 points there, so that can happen. It's crucial to understand that you may sometimes have problems. Don't look at it like in the movies, because most porn actors use substances and years. Some people are genetically gifted, which is normal, and sometimes problems can occur. You all, I'm fine. Many of you think that erectile dysfunction is like this. The baggage or trailer of old age, as it's sometimes called, affects people as they get older, often by 40, 50, 60, or 70. Do some of you think that having problems with erections is normal? When you see an elderly man of 60 or 70, you may think he lacks a sex life, but that's not true. Here's an interesting study. 73% of respondents aged 57 to 64 have sex and do it regularly, and 53% of respondents aged 65 to 74 also have sex regularly. So when you say that erectile dysfunction at 50 is normal, it's not normal. Erectile dysfunction is not normal, basically, at any age. Erectile function is an indicator of a man's endocrine, physiological, and psychological health. Hormones decrease with age, blood vessels change, libido gets lower as you get older, and of course there can be some changes, but you shouldn't equate age with erectile dysfunction. That's not true. A healthy man should have sex. A man about 75 years old recently visited my office, and he asked me, "Doctor, I have problems with potency. The first time went well, but he says the second time is now hard, though before both times were always fine." I look at him and think, I wish I had your problems at 75 doing it again. Many can't even do it twice at 20. And that's why understanding whether you have erectile dysfunction or not is kind of a floating thing. Really, everything is understood in comparison. Someone comes in and says they used to do it 5 times a night, but now only twice, asking for help. He'll be fine. Many things people see as problems aren't actually issues, and everything is very individual. And vice versa. Many of you may think that your sex life or urination is normal, but when we objectively start to look at it, we realize that it's not actually that normal. It's just that a person has already gotten used to it and has nothing to compare it to, because by nature they have a weak sexual constitution. The second thing I wanted to discuss is if this always indicates psychological problems. Right now, I know that my viewers are mostly young guys, mainly between 25 and 35 years old, but there are also guys who are 15, 18, or 20 years old who watch as well. When you haven't had any sexual experience yet, or let's say it's your first time, especially if you were nervous, maybe at graduation, it doesn't matter, you drank and it didn't work out, you immediately start having some problems. For example, someone who has never masturbated, had an unsuccessful first sexual experience, and only knows about sex from watching pornography. By the way, I don't approve of that. And of course, what does he start thinking? The problem is in his head. Young age equals psychology, psychological problems that come with being young. There can't be problems with blood vessels, hormones, or veins. 75% of patients who have problems between the ages of 18 and 25 have endocrine causes behind their issues. But having an endocrine problem, for example, obesity, lack of physical activity, low iron levels, low ferritin, low vitamin D levels, or high levels of stress hormones, naturally in such conditions, something doesn't work out for you. It might seem like it's because of hormones, but it's actually because things didn't work out. You start fixating on it, you start thinking about it, you start masturbating, checking yourself, comparing yourself. You start comparing what works for you with pornography to what works in real life, comparing yourself to the actors of pornographic movies, and you start winding yourself up even more psychologically. So you really did have a problem with hormones, but not just with hormones, let's say with your test results as well. And then you develop a psychological problem. It's especially hard when people avoid the doctor for a long time, don't seek answers, and try to handle things themselves. Everyone says, do you have a psychological problem? You just need more confidence at your age, try things out. He tries and tries and tries, but it doesn't work, it doesn't work, it doesn't work. His problems just keep getting worse and worse and worse.
Insanity is doing the same thing over and over again, hoping for a different result.
The guys who come in say, Doc, I've had these problems for years now. And what's most interesting is that after 2-3 years, in an attempt to somehow improve their sexual function, they start working out and watching their diet. Their test results become normal, their testosterone levels go up, and their body mass index goes down. And in fact, according to the test results, everything should be fine, but it's already not fine. Because these psychological problems that are formed lead to a situation where the guy is broad-shouldered, handsome, already all pumped up. But he hasn't had sex for 2-3 years. 2-3 years he hasn't, because he already has psychological problems. Today I'll explain how to identify if a problem is organic, psychological, and where to begin diagnosis. Is impotence a sentence? In fact, in 95% of cases, it's absolutely curable, it's absolutely reversible. But most often, all the pharmaceutical companies and doctors don't treat the root cause. You go to a urologist and he gives you, here you go, Viagra, here you go, Cialis, here you go, any other similar medication. He says, Doc, I don't want to take medications at 25 or 45. Is there another option, since people want to live without it and not rely on it? All the time in his breast pocket. He comes to me and says, there's a problem. He says, well, I walk around all the time, I have a pill in my breast pocket, and I always try to figure out when I'm going to have sex so I can take it without anyone noticing. I'm always worried that someone might see me taking something, that it's some kind of medication. And this psychological attachment to the pill, it actually takes a long time and is hard to get rid of, even when we are recovering, even when everything is already fine. He's grown accustomed to it after so many years. Taking medication before sex is already difficult for him. Remember, 95% of situations can be cured, not just managed. Not just to suppress it short-term or boost potency or erection with medication. Because most of the time, people just want to make money off patients and simply give us a temporary medicine. You stop taking it, it stops working. So please always treat the root cause. Try to find it and try to address it directly. So, what actually affects erectile function and how? Simple things that you all know well. Smoking, erectile function increases by 25% if you quit smoking for 1 year.
Since my addiction to cigarettes made me impotent, I rarely interact with women.
Physical activity improves the quality of your erection by 25 to 30%. Yes, many say that sports themselves have an effect, including the endocrinological changes that occur as a result of exercising. And sports are always about being smart. If it's done, it's always proper nutrition, it's the right daily routine. Because a person who works out regularly 3, 4, 5 times a week is usually someone who either becomes disciplined or is already disciplined. In addition to sports, the Mediterranean diet, here's a link to the study by the way, also affects the quality of your erectile function. So we eat right, get rid of bad habits, train properly and wisely, and we improve ourselves first and foremost, not just on the outside, but as men. There are also unusual things, unfortunately, and I say unfortunately because there are things that irreversibly change the quality of our sex life and erections. For example, my PhD thesis was about penile fractures. Yes, you can break a penis, and unfortunately, one of the consequences of a penile fracture is the development of irreversible erectile dysfunction. The tunica albuginea ruptures, the corpora cavernosa rupture, and all of this eventually becomes sclerotic and fibrotic, especially if surgery isn't performed within the first 24 hours. The second case is priapism. Sometimes guys try to impress someone, their new partner, and they take drugs to enhance their erection. And they're happy. The intercourse is over, but the penis doesn't go down. They're happy about it. As long as it doesn't last for 4, 5, or 6 hours straight, the erection doesn't go down. That is, the arousal is already gone, but the erection doesn't go down. This is called priapism, and it's dangerous because priapism most often happens due to thrombosis, meaning the outflow is disrupted. It's the same as tying a tourniquet around your arm. What will happen to your arm if it doesn't have adequate blood flow? That's right, they begin to die. The cavernous bodies, they start to die. Some patients wait 2 to 3 days before seeking help for priapism because they're scared and spend time Googling the condition. Acidosis develops in the cavernous bodies, causing them to stop functioning properly. Then they stop releasing nitric oxide, which is critically necessary for a healthy erection. Secondly, fibrosis develops, meaning the sexual shield begins to contract. And in many European countries, in the United States of America, and here as well, if a person comes in with a 3-day priapism, they immediately get a penile prosthesis. Because even if after drainage, clot removal, and flushing with an adrenaline and heparin solution, the erection is restored, it will definitely go away in 1.5 to 2 months. Therefore, it is essential if after taking medications or an injection of a medication that enhances erection, you develop priapism, see a doctor immediately. See a doctor immediately, under no circumstances delay. The sooner you come in, the sooner you start treatment, the more chances you have to preserve your erectile function. The next problem that leads to erectile dysfunction is Peyronie's disease. There was a scientist and doctor named François Gigot de la Peyronie, and he discovered this disease. A plaque appears on the tunica albuginea, and you can always feel it with your hand. It's dense and hard. This plaque typically has 2 stages, initial appearance and active growth. And it can curve the penis, it shortens the tunica albuginea on the side where it appears and causes curvature. This is the least of the problems that this plaque can cause. Sometimes a plaque appears and it grows into the corpus cavernosum, simply blocking the blood flow. Because of this, the penis can sometimes really look like an hourglass. And in this spot, by the way, there's a higher risk that some kind of fracture might occur. Peyronie's disease is one cause of erectile dysfunction. Another cause is prolactinomas. These are benign tumors in the pituitary gland that secrete prolactin and prolactin. First of all, it reduces testosterone synthesis in the body and completely kills your libido. So if you have high prolactin, problems with erectile function, the first thing you need to do, the very first thing, is to lower your prolactin level. There is a condition called chronic pelvic pain syndrome, which basically exhausts and torments a person so much that, as a result, they develop erectile dysfunction. But often, chronic pelvic pain syndrome is actually a mask for endocrine or neurological problems. There is also progressive sclerosis and sometimes spinal cord injuries, which can also lead to erectile dysfunction. In other words, erectile dysfunction has many causes and many disguises. So it's extremely important to clearly understand which specific case we are dealing with today. Anemia indeed is one of the rare but still possible causes of erectile dysfunction. Therefore, the first thing we should do is get a complete blood count to see if everything is okay with the red blood cells. The second thing you should always check is your cholesterol level, cholesterol, high-density lipoproteins, low-density lipoproteins, and see if you have any signs of atherosclerosis. Because the first blood vessels to suffer are not those in the brain, but our heart and our penis. Sometimes this is a predictor. Therefore, when a young man comes in with vasculogenic erectile dysfunction, meaning it's due to insufficient blood supply to the vessels, he should always be referred to a cardiologist and have his biochemistry checked. The third is problems with the liver and problems with the kidneys. Indeed, with liver failure and kidney failure, there can be problems with erectile function. You may have issues with blood pressure, either low blood pressure or, for example, on the contrary, high blood pressure. Therapists give you medications that normalize it. Many of them have side effects. For example, beta blockers can cause decreased erectile function as a side effect. If this happens, talk to your therapist about your treatment. Changing medication might help you feel better. Regarding the liver problems often lead to an increase in what we call our favorite aging protein. This is sex hormone binding, globulin sex hormone binding. Globulin increases, it becomes too high and not physiological for your age. Because of this, excessive binding occurs. Even if free citron is normal, as you know, sex hormone binding globulin also modulates receptors. That is, in addition to binding testosterone. When there's a lot of it, even if there's compensation due to high total testosterone, it still doesn't allow it to fully. It also impacts metabolism, raising sex hormone binding globulin levels. Check what's happening with the liver. One possible reason is some kind of liver pathology. Your sex hormone binding globulin has increased, your testosterone is conditionally blocked, it doesn't work properly, and you develop erectile dysfunction. That's why erectile dysfunction is like a tangled ball of yarn we unravel, often leading to unexpected problems. A person visits for erectile dysfunction but ends up diagnosed with ischemic heart disease. Hormones, but not the usual ones you expect, it's thyroid hormones, not testosterone. Indeed, when a person has thyroid gland problems, they may also have issues with erectile function. That's why checking your hormones isn't just about testosterone, you need to look at everything together. Because thyroid hormones, when the thyroid gland is dysfunctional, can also have a strong effect on sexual function. That's why with hypothyroidism or a thyroid deficiency, it can take a month or two to recover from decompensation before sexual function returns. A person finally wants to have sex. Urine analysis is essential. Although it doesn't reveal kidney function, it can detect things like sugar. That's why we always use a general urine test for screening. Sugar, it can reveal that we have diabetes, and diabetes leads to problems with our blood vessels. The next test that we sometimes do is an ultrasound of the blood vessels of the penis. Sometimes you request this test yourself and have it done. There are two main types of pineal blood vessel ultrasound. One is when it's done on the penis at rest, the other when done on the penis in a state of erection. Naturally, you shouldn't have an erection in front of the ultrasound doctor, that's why it's done with the help of injecting medication into the cavernous body to create an artificial erection. Nocturnal tumescence. Many people know that the penis becomes erect at night. There are many episodes and these erections last a long time and they're not related to arousal. Sometimes guys come in and say, nah, they have no erection. There's just none at all. There's no erection during masturbation with pornography or with a sexual partner. But then we start diagnosing for nighttime erections and it turns out that all night long his penis is firm and erect. There are special devices that are attached to the penis and they record the duration and firmness of the erection. This is very important because we need to know if the patient is physically, physiologically able to have an erection. And sometimes this knowledge, this understanding, in fact, this is quite a big step forward in the progress of treating erectile dysfunction that allows patients to benefit. Because when a patient understands that the problem may be purely psychological, it's much easier for him to accept it and it's much easier for him to undergo therapy. Barotheciometry is another research method used to assess nerve sensitivity and conductivity. We also conduct a study using tomography, typically with contrast, but sometimes without. We assess how well blood flows in and out and examine the condition of the vessels, especially the arteries. A question from the chat. After COVID, my erection has gotten worse. Could there be any connection? Yes, studies show that after COVID, testicular tissue and Leydig cells can often be damaged, either reversibly or irreversibly. They produce less testosterone. or chronic inflammation, which persists in the body for a long time, worsens the effect of the testosterone that you might have at normal levels. Therefore, yes, indeed, after COVID, either temporarily or for a long time, and sometimes even permanently, erectile dysfunction can develop. If you have this after COVID, get it checked. A question from the studio about testosterone levels. Will testosterone always improve your potency and your erection? Sometimes testosterone worsens, and even after normalizing low testosterone, erectile function may not improve. So you shouldn't think that testosterone is the answer to all questions related to erections. Just as you can have a good erection with low testosterone, you can also have poor erections and low libido with high testosterone. Hormone replacement therapy isn't always necessary. If you have endocrine issues, look for underlying causes. There's another research method, dynamic infusion cavernosography. What does that mean? Infusion cavernosometry is another option. We inject fluid into the penis and observe at what rate we need to inject it to maintain an erection. And the same thing is done using computed tomography. With contrast enhancement, we're looking for venous leaks. We've covered quite a few studies today. What can they offer you? Let me make a guide for you right now. So what should a person do if they're experiencing erectile dysfunction for the first time? First, we take the simple International Index of Erectile Function, 5 questionnaire, and fill it out to assess whether we really have a problem with erectile function. And if we see that our score falls into a certain category, then we move on to the next step. If you see that something didn't work out somewhere, but you're still within the normal range, please don't self-medicate or self-diagnose. Stop at this point. The next step, if we have any issues specifically with erectile function, is to determine whether there is an endocrinological factor involved. That's why I recommend at least checking the basic sex hormones. Third, we should always ask ourselves the question, I have erectile dysfunction. Does it happen all the time or not always? Or is it only with one partner, or for example, only with a partner? Masturbation is usually unaffected, but erectile dysfunction typically occurs in all situations. This is an important factor because with psychological causes, the problem often occurs in a specific situation with a specific partner. But during masturbation, everything is fine. Sometimes excessive masturbation and porn addiction themselves can lead to erectile dysfunction. And the most important thing for you is to understand whether the problem is mainly psychological, mainly hormonal, or mainly organic. Because all three of these areas are treated in principle by different specialists. But if you have a psychological problem, when a psychologist helps you, you'll feel better and everything might go away. Sometimes, even if you find an endocrinological problem, a psychologist's help can be useful since you've dealt with it for a long time. That's why therapy for erectile dysfunction is always comprehensive. It always involves lifestyle modification, introducing healthy habits, proper nutrition, exercise, and taking some dietary supplements. And as the cherry on top, if there are indications and nothing else has helped, if you've changed everything in your lifestyle and endocrine problems still remain, then sometimes hormone therapy is needed. And the last thing I sometimes want to give patients is medication to enhance erections. The dumbest thing you can do if you have erectile dysfunction is to just take Viagra or its analogs. Just take Viagra or its analogs. Because you remember that erectile dysfunction is often a marker of serious health problems in the male body. A marker, and it doesn't matter at what age, so don't treat erectile dysfunction as something trivial or insignificant. Sometimes it is a mask for a very serious condition.